Welcome to this explainer. Today, we're diving straight into a truly fascinating high-stakes medical process, transvaginal ultrasound-guided oocyte recovery, or just TVOR for short. If you know anything about IVF, you know egg collection is the absolute cornerstone of it all. Relying on an incredibly detailed presentation by consultant gynecologist and reproductive medicine expert Dr. Jude Adege, we're going to map out the anatomy of this procedure. We'll look at the exacting standards, the specialized gear, and the intense micro-precision needed to actually pull this off safely.
So here's our roadmap for today. We'll start with the evolution and core objectives, move on to the essential prep and trigger injection, and then cover the tools of the trade. After that, we'll walk through executing the procedure, and finally, wrap up with post-op recovery and risks.
Section 1. Evolution and Core Objectives.
You know, to really appreciate why TVOR is the gold standard today, we kind of have to look back at how invasive things used to be. Back in the 1970s, collecting eggs literally meant a laparoscopic surgery with a 3-portal entry into the patient's abdomen. Fast forward to the early 80s and the field moved to a transabdominal, transvesical ultrasound approach. Better, for sure, but still not ideal. The real game changer happened in 1984. Pierre Dellenbach and his colleagues in France developed the transvaginal ultrasound-guided approach, TVR. And honestly, it completely revolutionized the field by offering a much more direct, way less invasive route to the ovaries.
Now, because we are dealing with the literal building blocks of life here, the rules are insanely strict. The main goal, collect good quality oocytes, whether that's for IVF, ICSI, cryopreservation, or even an IUI cycle. But right alongside that, the clinical team has to guarantee absolute safety for the patient, the staff, and of course the incredibly sensitive eggs. That means maintaining a pristine, sterile environment, keeping ovarian punctures to an absolute minimum to reduce bleeding, and using highly specific suction so the eggs don't get damaged on the way out.
Section 2. Essential Preparation and Trigger.
Okay, before anyone even sets foot in the OR, we enter the super-critical countdown phase. Forward planning is everything here. The clinical team does a deep dive into the patient's medical history to spot any risks and runs mandatory swabs for infections, like chlamydia. They also carefully check the patient's BMI to figure out safe positioning and exactly what speculum to use. But here's a really surprising rule. Patients are told absolutely no soap on the vulva or vagina and 0 scented creams or lotions. Why? Because the volatile compounds in everyday toiletries can actually wreck the sterile environment and severely harm the gametes.
And this whole countdown phase really hinges on one very specific window, 34 to 36 hours. That is the exact time frame prior to egg collection when the trigger injection has to be administered. Whether it's a urinary HCG product or a recombinant version, this injection triggers the luteinizing hormone, or LH surge. And that hormonal surge is an absolute must-have to finish the final maturation process of the oocyte.
The stakes for getting that timing right are, well, huge. If that injection is missed, taken at the wrong time, administered poorly, or worst case, if the meds lost their bioactivity from being stored improperly, the eggs just don't mature. The result is a clinical nightmare called empty follicle syndrome. This means the team goes into surgery, does everything right, and despite all the planning, comes out with absolutely 0 mature eggs.
Section 3. Tools of the Trade.
Let's head into the clinic and check out the gear. Every single piece of equipment used in TVIF is custom designed to protect these delicate cells the second they leave the body. We're talking an ultrasound machine equipped with a highly specific 5 to 7 MHz transvaginal probe. Then there's the specialized aspiration equipment using 16, 17, or 18 gauge needles. You've got your vaginal pack ready with a Cusco speculum and plain saline. But crucially, the whole setup includes test tube warmers. The temperature control is absolutely vital because you literally cannot let these eggs be shocked by room temperature air once they're retrieved.
Section 4. Executing the procedure.
All right, stepping into the operating room, this is where the highly choreographed sequence happens. First up, the team must verify that trigger injection time. Then, administer the analgesia. Could be local, sedation, or general anesthesia. The patient is placed in the lithotomy position. Next, strict ID witnessing protocols are followed, and that crucial temperature control setup is locked in, because even a tiny temperature drop can irreparably ruin the egg structures. Then, the ultrasound-guided puncture actually begins. Once they've collected the eggs, they finish with a speculum exam to make sure there's no uncontrolled bleeding.
Actually, scratch that. Let me back up for a second because I really want to highlight a massive difference between TVOR and normal surgery. Usually, surgeons douse the operative field in povidone iodine to prevent infection, right? Well, in TVOR, they only use plain, normal saline to clean the vagina. They can never use standard antiseptic solutions because they are instantly highly toxic to the very gametes they are trying so hard to collect. It's a totally different ballgame.
Next, we hit the true Goldilocks metric of the entire operation. The suction pressure pulling the fluid and the egg out of the follicle has to be dialed in perfectly, right between 120 and 170 millimeters of mercury.
So why does that 120 to 170 range matter so much? Well, suction pressure can quickly become your worst enemy. If it's too low, you get a frustratingly low egg yield, or the delicate needle just totally blocks up. But if you crank it too high, you cause severe egg stress. The intense pressure literally fractures the zona pellucida, that's the egg's outer cellular shell, leaving you with misshapen, completely unusable eggs.
Section 5. Post-op recovery and risks.
Now, the clinical team's job definitely isn't over just because the eggs are safely in the lab. Before a patient gets the green light to go home, they face a really strict final checklist. They need stable vital signs, minimal pain or nausea, the ability to walk and pass urine unassisted, and a responsible escort. The team has to be hyper-vigilant here, monitoring for serious complications. We're talking medication reactions, internal bleeding, pelvic infections, or even injury to the bladder or bowel. And of course, they're watching closely for OHSS, ovarian hyperstimulation syndrome, which is a major potential side effect of the fertility drugs.
In transvaginal ultrasound-guided oocyte recovery, precision isn't just some standard medical protocol. It's literally the fragile boundary between clinical failure and the foundation of a brand new life. Think about it. How many other procedures demand this staggering level of micro-precision just to give life a chance to begin? From banning regular soap, to ditching standard antiseptics, to dialing in the exact millimeter of mercury to protect an invisible cellular shell, it's absolutely incredible. Thanks to experts like Dr. Jude Adegame mapping out these meticulous principles, clinical teams can safely navigate that boundary every single day. Keep exploring, keep learning, and until next time, stay curious.